an excellent time to be practicing dermatology, so are you ready for Therapeutic Hotline, where we bring you the latest advances from experts in the field. I'm Jim Del Rosso, a dermatologist practicing in Las Vegas, Nevada, and I have with me a good friend and colleague from Detroit, Michigan, Linda Stein-Gold, Dr. Linda Stein-Gold. So Linda, let's talk about rosacea, what's new, and some of the things that we've used and how we integrate into rosacea now. We've both worked on a lot of research projects and educational projects. So what about this new concept of not necessarily utilizing subtypes, but looking at the manifestations that the patient has on that day that we're seeing them?
I think that's such a critical issue. You know, we don't want to just put somebody in a bucket, but actually take a step back when a patient walks into your office and say, what are your signs and symptoms? Do you have background erythema? Do you have telangiectasias? Do you have papules and pustules? Do you have eye involvement? And we look at each one of these individual features and we address our therapy towards those individual signs.
It's interesting because we do that with acne and we look at different types of lesions and match it with different therapies that we know work better against comedones or nodules, but we've sort of not gotten into that thinking with rosacea. We need to think about rosacea as having different signs and symptoms with different therapies that address different components of the disease. I agree with you. I think it's so important. Now, what about the new alpha agonists that we have, like Rosacea and Rofade, brimonidine, and oxymetazoline? There has always been the question when a patient presents with papules and pustules and background erythema, which they typically do we utilize them together or do we wait on the alpha agonist? And I know we have new research on that. So what are you finding that you're doing now as compared to a year or two ago?
This is really an interesting topic because I love when data kind of slaps me in the face and tells me what I've been preaching is absolutely wrong. So in the past, I've said you cannot start an alpha agonist when you have papules and pustules in place because you take away the background erythema and the patient looks like they're more bumpy and they'll be upset. But as you mentioned, Jim, there's a new study that shows that if you actually start the two drugs together, an alpha agonist and an anti-inflammatory drug, in this study it was brimonidine and topical ivermectin, you actually end up with better results and even better results on the inflammatory lesions if you start them straight away. So I've changed the way I practice.
It really has been a game changer in terms of starting them both together. Now, if someone wants to wait, if they're still not sure, they're still going to get the benefit, but they'll do better if they use them in combination together. Now, what about oral treatment of especially papulopustular rosacea with utilizing something like doxycycline? Do you think it's important to be utilizing the sub-antibiotic dose versus an antibiotic dose?
And the sub-antibiotic dose, I think, is really important. And I'm going to tell you all a secret. I actually wasn't so on board, but Jim has been on this therapy for the past 10 years and hasn't missed a dose. So given that, I've really come on board.
Well, I think it's important, obviously, for reducing the risk of antibiotic resistance. And I haven't missed a dose of finasteride for alopecia also. So
there you go.
But my antihypertensives I miss, but those I don't miss. So when do you utilize oral treatment in combination with topical or topical alone? Is it based on the severity that the patient's presenting with on that day?
Yeah, it's really kind of, I look at every patient individually and I don't have a key recipe that I use. I just look at that patient, how quickly do they need to have a benefit? Are they willing to wait it out a little bit? And I really use all those tools in the toolbox to get the patient under control.
And we don't want to forget skin care, gentle skin care, because they have a lot of transepidermal water loss and they sting and burn a lot more easily. So the skin care is extremely important also in the management of rosacea. So it's an excellent time to be practicing dermatology. And so there you go with the management of rosacea. Thank you, Linda.
Thank you.